So next we'll have Dr. Roel Browne, who would be talking a bit about assessment and diagnosis. And Dr. Browne is a medical doctor who is happily married for 3 years, and he's been a physician for 7 years. And he attended the University of Manzanillo in Granma, Cuba, and he loves people and loves talking to people about their health.
Good afternoon to everybody. We are going to chat a little bit about how we normally diagnose diabetes and basically why we assess diabetics. So there are many ways that diabetes, many tests that you can use to diagnose diabetes. So we're going to find out, what tests do we use, when we use them, if we use more than one test, and why is it sometimes we don't use certain tests for certain individuals. Okay. Okay, next slide. Yes, so diagnosis. So as we can see, there are two tests there, and the first one is the fasting plasma glucose, which is the fasting test. As a doctor would say, well, you're supposed to fast, and the fasting time would have to be 8 hours to 12. So if you're planning on going to do a fasting test on Monday, we would say Sunday night. Here in St. Vincent, we would say the latest you'd eat between 9 and 10 p.m. in the night. And then in the morning, you don't have breakfast. Go and do your test. After you finish doing the test, you have your blood test done. You have your breakfast at that time. So we notice the fasting plasma glucose equal to 126 milligrams per deciliter or greater, so or 7 millimoles per liter. So this is one of the tests that we use for an individual so that we can find out whether or not they're diabetic. Another test we use is the oral glucose tolerance test. This one we use this one for pregnant patients. So this is the only time we use this one in St. Vincent. So as Doc had said before, between 24 and 28 weeks of gestation of pregnancy, we would send the patient to have initially at 0 hours, just before they drink a special liquid, which is obviously a special type of sugar, we would check their blood glucose. An hour after consuming this type of sugar, we would check it, and 2 hours after, we would also check it. Now, so if at the 2-hour mark, the sugar reading says 200 or greater than, then we know that this patient has some diabetes, gestation diabetes. Or next slide, please. Right. So one that most persons may have heard about is the A1C, which basically this tells us the average blood glucose for the past 3 months. So this test tells us that, for the past 3 months, your blood sugar has been elevated, and it must be, the numbers are very important. It must be at least 6.5 to or greater than 6.5. Okay, and we notice there are some organization there, so you have to ensure that in your country that the A1C are according to these standards. If they are not, well then you need to check with your health authorities to ensure that, because if that is not the case, then the reading that you may have can be incorrect. And last but not least, the old-fashioned way, where we would use symptoms So for instance, in medical school, they taught us that if the person is having, for instance, they're drinking a lot of water, they're urinating a lot, they're eating a lot, those are classical signs of high glucose levels. Plus, when they check their sugar level, it's greater, it's equal to 200 or greater. Most of the times, they're going to have what we call ketones in the urine. So this test plus the A1C and the fasting plasma, those are the three that would be used to diagnose an individual. Now, the oral glucose is specific for pregnant patients. Next, please. Next, please. All right. So assessment. No, go back. Go back. Back, please. So sometimes patients they come to the clinic or they see the physician, and sometimes it's just because they show up and they believe it's just because it's their appointment, so they just show up. But the real reason why you go to see your doctor or your nurse or your healthcare professional is to prevent or to slow down the complications from diabetes. And basically, there are two types of chronic major complications from diabetes, and we call them microvascular, meaning small blood vessels, and macro, meaning large blood vessels. Next slide. Right. Now, as we can see on the stream, make it a little bit larger for me, please. No, a little bit. Right. So here we can see that one of the major chronic complications, the first one you can see is that diabetic retinopathy. So, and it says this is one of the leading cause of blindness in the world. So according to the statisticians, about 5% of individuals who are diabetic worldwide, they're going to develop this complication, and the incidence is increasing. The other complication that we have there, we notice that there's diabetic neuropathy, and that is nephropathy. That is one of the leading cause of end-stage renal disease. As we know, diabetes uncontrolled, that's the number one cause. And the last but not least, we have the diabetic neuropathy, which is one of the leading cause of non-traumatic amputation of the extremes, which would be like legs and up and limbs. And on the macrovascular complication, we have stroke, we have heart disease, and we have peripheral vascular disease. Next, please. Next, please. Yes, so diabetic retinopathy. So there is, in the eye, there is a very sensitive area that is known as the retina, and that is responsible for taking the light and taking the light from the outside and sending it as messages to the brain so that we can have an image. So basically, that is what allows us to form an image in our eyes. Now, what happens when the blood sugar gets elevated? It can cause damage to their veins and arteries in that area, and constantly high elevated blood sugars can lead to damage or swelling, which can eventually cause these blood vessels to burst, and then the blood would spill into the entire eye. Now, some of the symptoms a patient can experience or come to the clinic as a result of this problem is that they can say, well, doc, I noticed that when I would normally feel as if something is floating in the eye. Some would say that they see spots, their vision is blurred. So this is one of the complications of elevated blood sugar. And as a result, when you go to your doctor, this is why it's recommended that each year, on especially on being diagnosed, it is recommended that we do one. Normally, we as doctors, we would like to talk about baseline. So you have a baseline. So when you, especially, well, type 1, you get one. Type 2, as Doc said before, you could have had diabetes for many years and you don't know. So when you do it, you can find out that, okay, maybe you already have some damage being done. Now there are 4 different stages of retinopathy. We have the mild, the moderate, we have the severe, non-perfect, and then we have the severe, the perfect, where it's start to spread entirely through the eyes. So that is why I would say again, it's recommended that each year you check your eyes. Normally here in St. Vincent, most of us as doctors, we don't have the instrument to check, so we would refer the patient to the eye specialist. I know overseas it's a different story, but here in St. Vincent, that's what we do. So if you go to your physician and years have passed and you haven't had your eyes checked as a diabetic, you should actually, say, doc, well, that's been a while since I haven't gotten my eyes checked. So look into that. Remember, the eye is the window of the body. So if the vessels in the eyes are damaged, likelihood they are damaged elsewhere in the body. And our next complication is diabetic nephropathy. So here in St. Vincent, we have noticed an increase from since 2017 to 2021. The numbers are increasing year by year. And worldwide, it's also the same. Now, we know that the importance of controlling your glucose level is that this is one of the major reasons, because it's the leading cause of end-stage disease. So some of the symptoms an individual might present to the clinic with, for example, they might come with decreased appetite, they might have also they might have chest pain, they might have difficulty breathing, unexplained elevated blood pressure. So you saw them this week, you put them on a medication, they keep checking the blood pressure, they come back the next week, it is still elevated. You change medication or you add another medication and it's still elevated. Now, that is something to think about that maybe this individual may have. So unexplained elevated, unexplained low blood, that's one way of also of thinking that there's a possibility that it can be related to the kidneys not working well. I've seen a patient where, I've heard of a patient where, early 40s, where she wake up one morning and she had intense knee pain. And she went to different doctors. She was known to be hypertensive and diabetic. She went to a whole set of doctors, did a whole set of tests, had x-rays done, and still no cause. When she went and she saw the nephrologist, after asking her, well, what are all the tests? She said to her, no, you need to go and do a kidney test. When they did the kidney test, unfortunately, she had end-stage renal disease. So unexplained arthritis, knee pain, that is something that possibly can be. Okay, so you would have the shortness of breath because there might be fluid, and the fluid may have maybe all the way up to the lungs, and that would explain why this individual may have shortness of breath. Sometimes these individuals would come with we would say swelling edema, so swelling to the ankles, to the feet, etc. Next slide, please. Next, yes. So neuropathy, so diabetic neuropathy. So okay, so in this case, a patient can present with numbness, sharp pain, intense pain. Sometimes they describe it as needle prick. Okay, there are actually 4 types, but I'm only going to mention in short 2. So normally the one that most of us would present with would be the one that we call the peripheral neuropathy. This is where the person would complain of the numbness to the foot and to the legs, sharp pain. Sometimes they describe it as needle prick. And the one that is the most dangerous, we call it the autonomic neuropathy. This is where the part of the brain is in control of the blood pressure, the heart rate, the sex organs, the bladder, the digestive system, the eyes, sweating, etc. So the patient comes to the unit and there is their blood pressure, their blood sugar is low, but yet they are unaware of it. Sometimes men and women, sometimes they have difficulty, as we would say in the local language, they have a difficulty to come up, have an erection, and as a result, they might think it's something else. But this is one of the cause of it. Okay, so this is something that these are some of the symptoms that we can look at. So a patient should be examined. So you normally would have your pinprick. You'd also have what we call the tunnel, what we call we normally use, so if we don't have all the right tools, we'd use the pin prick, we'd use our fingers, etc. Also, there's the tuning fork, etc. Next slide, please. Next slide. Right, so stroke, this is one of the major complications, and this results in diabetic because most of the times we could see that they also have what we call plaque. So plaque would be built up in an artery, and as a result, it leads to decreased blood flow. And we know the signs and symptoms of that. So for instance, the patient would have slurred speech, patient may have weakness on one side of the body. So as a result, they're not able to amputate. So these major macrovascular complications, these are the leading cause of death worldwide in diabetics. So this is why it's very important that your cholesterol, that as a diabetic, you have a cholesterol check. You know, you reduce the trans fats and the saturated fats. You do exercise, take your medication. Next slide, please. And the heart. So it's similarly to stroke, we have the heart. So same problem where there is plaque, which is fat built up in the arteries. It stops the blood flow, and as a result, there is death in that area of the heart because lack of blood flow would mean lack of oxygen, lack of food, and then we end up with what we would know as a heart attack. So normally patients are advised on diagnosis to get the EKG done. So we have normal EKG, resting EKG, and you would have the one that you would do, what we call the stress EKG. Next slide, please. And what most persons in our country would call poor circulation. So basically, here you would have patient complaining about pain in the feet. Also, we would notice that there is loss of hair. Sometimes they have sores, and the sores would take a very long time to heal. On examination, we would notice that there may be no pulse or reduced pulse. And as a result of this, we can have a increased risk. There's increased risk for amputation. Next slide, please. Thank you.
So Dr. Browne has a video to share, but it's about assessment.
Paying attention to warning and danger signs, and taking simple measures to protect and care for feet, it is possible to prevent most foot ulcers and amputations.
Do you know that in a lifetime, a human being walks about 100,000?
You want to change?
That's like walking around the world almost 4 times. Now imagine, halfway through your life, having to do this on 1 foot. Or even on a wheelchair. Hello, I'm Dr. Fitfoot. Do you see now how much your feet support you in your lifetime? And tell me, how much do you support your feet? This question becomes critical for those who live with diabetes. Wherever you may be, Asia, Africa, Latin America. Do you know that apart from accidents, maximum foot amputations are done on people with diabetes? The reason is they don't feel pain in their feet, and that's the problem. If you live with diabetes, this video gives you basic tips on foot care, so you can lead a healthy, productive life. This video is broadly divided into do's, don'ts, and danger signs. First, the do's. Use a mirror to check your feet daily. Look for cuts, bruises, blisters, color changes, swelling, ingrown toenails, and open sores. Always protect your feet against injury by appropriate footwear. Keep wounds covered with clean dressing. Wash feet daily with soap and water. Take care to wash between the toes. Dry feet carefully, especially between the toes. Keep skin soft by using lotion on the top and bottom of your feet, but not between toes. Preferably, do this at bedtime. Cut toenails straight across and file the sharp edges. Before putting them on, check shoes daily for rough places, any irritating objects, pebbles, nails. Wear cotton socks that are washed daily. They must fit well and have no holes. Buy shoes at the end of the day as feet swell during the day. Avoid rough seams. Wear them for short periods at first. Have your feet checked by your doctor periodically. Now let's see what you should avoid. The important don'ts. Don't let your feet get dry and cracked. Don't go barefoot, either indoors or outside. Since the diabetic foot does not feel pain, see what can happen until gangrene sets in. Do not use hot water to wash your feet. Don't wear torn or tight shoes, or shoes with rough and uneven seams. Avoid shoes with narrow toe box. Sandal with thumb between toes. Or footwear that have just straps and no back support. Don't wear tight socks. Do not use corn medicines, blade, knife, or any sharp instruments. Do not use a hot water bag. Or warm your feet at the fire. You may burn them. You should avoid smoking too. Avoid visiting religious places in the hot sun. You may burn your feet. Ensure your foot is not in contact with the exhaust pipe of a motorcycle. Now let me tell you about the danger signs. If you become aware of any of these danger signs, seek help from your doctor immediately. Your foot becomes painful. Your foot becomes noticeably red or has any unusual discoloration. You feel a part or all of your foot is much hotter than usual. There is a discharge of any kind from your feet. Your foot smells bad. Your foot has an open sore or blister. You feel generally unwell with nausea, vomiting, or high temperature. You have unusual difficulty keeping your blood sugar under control. Please follow these guidelines unfailingly. Your doctor can only advise. It is your foot. Remember, foot problems will not be painful, but can still be very serious. You have to act. After all, we have a long way to go, isn't it?